guys. Welcome. Can you see my screen? Like you
Yes,
do.
we can.
Awesome. Is it like is it a showing you the whole slide or is it like the presenter view?
Nope, it's the whole
Slide.
slide.
Awesome. How's Wednesday going here? Busy, I'm sure. Yeah.
All the titrations and
Right.
retitrations.
I thought that was Friday. It's Wednesday and Friday, right? So re-titrations. Yeah, the fifth goes. Yeah.
That is actually one of my patients. It's like a re chapter.
Lot of the re's.
Yeah, with parasomnia montage and teeth.
Oh, no. Give it a few more minutes and see if anyone joined a little late. Yeah, that look good. You don't have to talk though. 'Cause mouth might be full, but like good.
What?
Oh, I was just saying that looked good. Yeah.
Oh,
I was saying you don't have to answer me if you're eating.
Oh.
Good. So I don't.
did pretty good. Chocolate chip croissant.
Oh, so that's even better than so they look. All right, maybe I'll just give a couple more minutes because I know sometimes everybody's finishing up, sometimes finishing up another meeting even, uh, which sometimes runs late. Okay, so I'm gonna go ahead and start. I have no pertinent disclosures to make other than, and I did present this late last summer, but many faculty were away on vacation at that time, and also we have some new fellows now and some new faculty, so I thought I would represent a couple cases that I did before. But if you've seen this and you know it already and you need to do some multitasking behind the scenes, that is totally allowed. So so the first case I have two, and I think we can get through them both, but I want to make sure that we have some time for Megan because I'm the opening act for her. So I want to make sure that we give her enough time. So the first case, I have a 32-year-old gentleman. He came to me with the chief complaint of abnormal sleep behaviors. He described acting out his dreams since age 28, so for about 4 years. And he described kicking, hitting, swearing during sleep with dream recall. He recalled acting out a dream that he was a hockey goalie. Most often the dreams had a violent nature where he would be fighting. He hit his wife once. He denied injuries to his wife or to himself. Most vocalizations were swearing. The episodes typically occurred once and rarely twice per night. He had comorbid anxiety. He was treated with several antidepressants, though the dream enactment behavior appeared to persist off treatment. And the dream enactment behavior, it was about 3 to 4 times per week when on SSRIs, and once per month was an estimate when not on SSRIs. So coming to me, he was on Lexapro 20 milligrams in the morning, also Trazodone 50 milligrams at night, and he was having 5 of these episodes per month. So any additional history that you would ask him that you would want to know, given some of these details that you have, and feel free to shout it out. It's a little hard for me to see the chat if you're able to shout it out. Any thoughts? Any additional things that you might want to know?
Any substance use?
Good question. No substance use. It's an important question. Excellent question.
Any history of seizures, PTSD?
I heard something in the background. Oops.
Any history of seizures or PTSD?
Yeah, seizures or PTSD. Great question. No history of seizures. No other pertinent medical history, and no history of PTSD. That's an excellent question too. Other thoughts? These are all good things.
When do they happen? Like
When do they happen? Yeah, they tended to. He had a tough time giving me that answer, but it seemed like they weren't right when he fell asleep. They were more in the latter portion of the night. Good questions. So excellent question. So he gave me some of that. I'm gonna so a few other things that he provided or I asked. He denied any sleepwalking. None in the last 4 years with these episodes or earlier in his life, including childhood. He denied awakening confused. So when these would happen, he was oriented really quickly. He denied any tremors, no slowed movements, no loss of smell. He didn't have any history of PTSD, as Punitha asked, no history of head injury either or trauma, no history of sleepiness, cataplexy, no hypnagogic or hypnopompic hallucinations, no sleep paralysis. He also denied snoring, witness apneas, headaches, dry mouth, no sore throats upon awakening. He had vivid dreams, but denied nightmares outside of the violent dreams that he recalled that he acted out. So with that history, would there be any testing that you would do or that you think he would benefit from? And I guess, what are you thinking with the history? Any thoughts?
In terms of a young person,
Yep.
like a REM sleep behavior disorder should be more on the rare side. But even with all these other signs, sort of echo.
There may be, but I appreciate the thoughts. Yeah, it's and I was able to hear it, but yeah, questioning REM sleep behavior disorder, but seems young. So could
Yeah.
be something else. All good thoughts. Would you do a sleep study? And what would you be doing it for?
Well, to do like with a parasomnia montage.
Yeah.
Just to see what happens.
Yeah, I think it could be useful to do here, just to clarify. I mean, we're wondering about REM behavior disorder. Do we see it? Do we see loss of, do we see REM sleep without atonia on the study? Is there some sort of other parasomnia that's happening? It doesn't seem like it from the history, but those would be good things to look for on the test. And then I guess it doesn't seem like there's sleep disorder breathing, but if he did have obstructive sleep apnea, that might contribute to dream enactment behavior. So a sleep study was done. Now, he came to me and had this testing completed. So this was done in an outside institution, but the first study showed mild obstructive sleep apnea. And I highlighted some things in bold that I thought were important or that jumped out at me when I looked at it. There was some somniloquy. The AHI was 11, minimum oxygen 91. Sleep efficiency was a little bit lower. They noted no snoring on the study. REM latency was prolonged. That suggests against narcolepsy. There was no loss of REM atonia. They noted that at the time on the sleep study. Somniloquy was once noted during REM sleep, but they didn't comment about any loss of REM atonia. I don't know if the patient was on an SSRI or any other antidepressant at the time of the test, or if they were stopped. They came back a couple years later and had a repeat sleep study. Again, they thought that there was some obstructive sleep apnea, predominantly obstructive hypopneas. 82% of the night was supine. Sleep efficiency was again lower. They mentioned no snoring.
Yeah, but essentially,
EMG was normal. And then eventually came for a titration where on that study, sleep efficiency was pretty low. There were some centrals noted. They did make a note of non-REM parasomnias where they thought there was a confusional arousal and sleep talking. Again, they mentioned atonia was preserved during REM sleep. The patient ended up getting ASV. So how would this change your thinking and any additional tests that you might want given this? Do you still think that he would have REM sleep behavior disorder even though they didn't catch any or document any loss of REM atonia? They definitely looked for it. They commented on it. There's not necessarily one right or wrong answer. So that's a question in my
less
mind.
likely is what I would say. But
Say it
maybe you
again,
can't. I said it's less likely if
Mhm.
there's no sort of no loss of REM atonia. Could he still have RBD? I don't want to say no, never, but I would say it's the likelihood of that happening might be less likely.
Okay.
Yeah.
Maybe lowered, made you question it a little bit, question that diagnosis of REM behavior disorder a little bit. Okay. It's a good thought. So yeah, and that's a question. So often we're seeing loss of REM atonia right on many studies, certainly when folks are on antidepressants. Here we didn't see it on 3 despite that history. He did have some non-REM parasomnias here, a confusional arousal. Somebody would be obviously by the name, but confused after non-REM parasomnias. He was really oriented from history. So his history suggested more like a REM behavior disorder kind of presentation. So additional testing, he had an echocardiogram. That study was normal. That was done given the central sleep apnea. He had an EEG done. That study was essentially unremarkable. They did notice though that one recorded spell of yelling occurred out of REM sleep without any electrographic ictal correlate. Actually, this was done outside as well, and I'm not sure. I'd have to go back to see if it was like a 24-hour EEG. Normally, we don't capture REM sleep on an EEG, so that's a little atypical, but usually when you'll see an EEG done, they will comment sometimes on if the patient does sleep. It'll be usually a couple-hour recording that somebody will have, and sometimes they'll go into usually non-REM sleep. Then the patient did have an MRI that was normal. In part, this left temporal delta slow waves could indicate some focal pathology there, so an MRI was done. It was normal. Also didn't show any sort of secondary cause of RBD that might be present. So the patient came to me. I know, Firouz, you mentioned, given the loss of REM atonia, would he have REM behavior disorder? He came to me with that diagnosis. He had been on melatonin, 10 milligrams, and that was ineffective when it was tried. He had tried the ASV, and that he couldn't tolerate. He was trying a mandibular advancement device for sleep apnea. But the one thing that stuck out, one thing that we really talked about probably the most in the visit was, since he learned that he had RBD, that he was diagnosed with it, and he learned that it could be associated with Parkinson's disease, he'd been more anxious about his health for 4 years. He'd established care with a therapist who he'd been working with for the last 3 months. He was followed by psychiatry. So he did have anxiety that predated his diagnosis of REM behavior disorder, but the anxiety and depression, they markedly worsened after he learned that he might develop Parkinson's disease. So RBD, so the diagnostic criteria for RBD, I just wanted to kind of highlight those. Those are in the ICSD 3TR. But so does he have RBD? So if you look at C, so we have to have repeated episodes of sleep-related vocalization or complex motor behaviors, so that we think are in REM sleep. So he does satisfy A and B. We think the disturbance is not better explained by another current sleep disorder or mental disorder. So I'm not convinced it would be like this pseudo RBD from history, without getting to it in more depth. But I actually was questioning the OSA diagnosis, even though both studies showed it. There was no snoring on it, so I even wondered if some of the events were central, and I wanted to look into the sleep apnea again. I wasn't convinced he had sleep apnea, especially from his history. He was very thin. I didn't go over his physical exam, but he had no real other risk factors for sleep disorder breathing. So I wasn't sure on that diagnosis. But so to me, there wasn't something else that it would explain this. I thought the only thing it didn't have is this polysomnographic recording demonstrates REM sleep without atonia, which is needed for a definite diagnosis of RBD. But if we look here, there are these notes in the ICSD-TR, and I want to highlight number 5. So this does mention that a provisional diagnosis of RBD can be made if we don't have REM sleep without atonia. And I don't think we have a lot of data on patients that do have RBD. Could we have some studies that how frequent do we see the loss of REM atonia for the patients that I have that clearly have RBD? That especially those that are older, that may have like an alpha-synucleinopathy, it's really pronounced. But could there be some variability in maybe other cases of RBD? How often do you see the loss of REM atonia? So it mentions here that you don't have to have it to make a provisional diagnosis of RBD. And that also might occur if there's somebody that maybe can't come into the sleep lab and you really clinically think they have it. So I would kind of give him a provisional diagnosis of RBD. And then I wanted to call your attention to 6, and it mentions that RBD can be diagnosed in the presence of central nervous system acting medications. Certain antidepressant medicines can contribute to REM sleep without atonia on polysomnography, without dream enactment behavior, and RBD. And then it mentions medication-induced RBD could signal or unmask underlying isolated RBD. So therefore, medication-induced RBD should be diagnosed as RBD pending future longitudinal studies. And that was a little bit of a change from how we looked at it in the past. So So right now we consider this still, I would consider this provisional RBD. And if he had the REM sleep without atonia, I would call this RBD. But certainly, as it mentions here, I think we need further studies to figure out, should we treat a presentation like this similar to somebody that is going to get RBD later, or is there even a different sort of pathophysiology going in some of the medication-induced RBD? And we need more data there. So subtypes of RBD. So there's isolated RBD. So that would be drug-induced RBD, should be classified in this category now. And we'd consider this patient to have isolated RBD, with a provisional diagnosis. And we'd use this unless somebody had Parkinsonism or dementia. So if somebody has RBD with Parkinson's disease, we refer to that as secondary RBD, or Lewy body dementia, multiple systems atrophy, or autonomic failure, which is a rare alpha-synucleinopathy where the synuclein deposits are typically in some of the autonomic ganglia. Narcolepsy type 1 would be a cause of secondary RBD. So that was, certainly a consideration given his age, but he didn't have a lot of the other symptoms, or any of the other symptoms that somebody would have with narcolepsy. He wasn't sleepy. Autoimmune encephalopathies could cause RBD and brainstem lesions. So those would be secondary causes. Another subtype would be your parasomnia overlap disorder. So that's a mix between, that would be RBD plus another parasomnia. So it could be a disorder of arousal, which would be your non-REM parasomnias, or sleep-related eating disorder, or rhythmic movement disorder. Sometimes in children, you could see parasomnia overlap disorder. Often, and one thing I would mention with RBD, pediatrics versus adults, often if you have RBD in adults, it could be more of the isolated type, but generally in pediatrics, it's almost universally secondary to another condition. And then a really uncommon subtype for RBD, there's status dissociatus, which is this a condition where there's lack of identifiable sleep stages, and you'll have sleep and dream-related phenomenon kind of interspersed. And there's a rare neurological condition, agrypnia excitata. I'm not sure how good my Latin is, probably not good, but it's a condition where there's generalized motor overactivity, impaired ability to initiate and maintain sleep, lack of slow wave sleep, and marked motor and autonomic activation. So we can see this with delirium tremens, Morvan syndrome, which is a rare autoimmune neurologic disorder that causes both peripheral and CNS involvement, where there's neuromyotonia, and it's where there are autoimmune antibodies to the voltage-gated potassium channels. Limbic encephalitis, not listed there, could also cause this. That can also have autoantibodies to the same potassium channel autoantibodies. And then fatal familial insomnia, which is a prion disorder that could be sporadic or familial. So those would be the subtypes for RBD. Differential diagnosis, sleepwalking, sleep terror. So what else could this patient have had, just going back to the history? Not a lot, in my opinion. Sleepwalking, sleep terrors, obstructive sleep apnea, which I don't think he had. We kind of looked into that a little bit more. Sleep-related hypermotor epilepsy. The events would be more stereotypical. Again, you wouldn't remember the events or dreaming out behavior. Rhythmic movement disorder, sleep-related psychogenic dissociative disorders, frightening hypnopompic hallucinations, PTSD, and then trauma-associated sleep disorder, which would be in the PTSD category, where there's often a dream enactment behavior with nightmares and autonomic arousal in response to trauma. So he was counseled that he might get Parkinson's disease. So what brought that up, and should we be counseling our patients about that? So why was that mentioned? Well, it is important to think about RBD and Parkinson's disease and other alpha-synucleinopathies. So especially most men greater than 50 years or older. So he's 30, 32, and he was 28 when his symptoms started. But most men greater than 50 or older that have isolated RBD do go on to develop an alpha-synucleinopathy. So that is why it's important. That's why we really I've been thinking about RBD a lot and looking for it. A large multi-center study demonstrated about 73.5% conversion rate to Parkinsonism and or dementia, often over a decade after an RBD presentation. A higher conversion rate of maybe 80 to 90% in a single smaller center study with a longer follow-up period. 94% of RBD patients showed an alpha-synucleinopathy post-mortem. Lifetime prevalence of Parkinson's disease is about 1 in 1,000 or 2,000. So just to give some comparison, how common is Parkinson's disease? And then we don't see RBD in all Parkinson's patients. So it's about in 60% of Parkinson's disease patients, 80% of patients with Lewy body disease, and more than 90% with MSA, which is multiple systems atrophy. And then there's it's thought that isolated RBD, and especially men greater than 50, could be thought of as prodromal Parkinson's disease or a prodromal alpha-synucleinopathy. A prodrome is sort of a non-specific symptom in what will become a specific condition later, but it is thought to also, you'll see this term prodromal RBD. So that would be like motor or vocal activity without definite dream enactment, or possibly with REM sleep without atonia that predates RBD. So, some of the REM sleep without atonia that we don't know what to make of on a sleep study, and we might mention that a little bit and try to downplay it in the reports. Could some of that and some of those patients be truly prodromal RBD? Might that patient get RBD later, even though they don't have it at the time we look at the sleep studies? So what should we tell patients with RBD? So counseling. So this was definitely given a lot of attention when we learned that RBD can be associated with Parkinson's disease, and potentially can identifying RBD early in somebody that will develop Parkinson's disease. That's led to a lot of research trying to better understand Parkinson's disease by trying to study those patients earlier to figure out what is happening, what's the pathophysiology of the condition, and can we lead to a treatment to prevent it, even though we don't have that yet. But should we tell folks that have idiopathic or isolated REM sleep behavior disorder, should we tell them what's coming? Was this interesting article by Dr. St. Louis, and in short, his answer was yes, but it goes into a lot more details in the article. So going back to the patient I saw in clinic, so he was told that he might develop Parkinson's disease, but boy, did it definitely I'm going to say, caused harm in him. Even though it didn't do physical harm, I mean, this absolutely impacted his life in a negative fashion. And again, had some anxiety ahead of this, but for sure, like his main focus of anxiety over the last 4 years when he went to see me was, I think I'm going to get Parkinson's disease. And we had to really work our way through that. So patient counseling, one study showed that about 47% of patients with RBD were counseled about the risk of an alpha-synucleinopathy in a medical record. Would and should your counseling of this patient differ from another patient with RBD? That's just a thought question for everyone. What factors would you use in your decision about counseling with a patient? And one thing to think about is patients will likely learn about RBD and that it's associated with neurodegenerative disorders on their own. So a couple principles that we're thinking about, respect for autonomy. So giving a patient knowledge about what's to come, their right to know, versus doing no harm. So maleficence, harm, so non-harm. So we want to do no harm as physicians. So kind of patient right for self-determination versus, we're trying to not harm them. So how do we balance all that out? And I think a challenge with RBD, because it's never 100%. So, and there's not clearly this actionable step. So even if you have a 55-year-old male, where I gave you those statistics, it's not still 100% that they're going to get an alpha-synucleinopathy, although it's getting high. So certainly in them, maybe there would be some things that might impact their life to know about, maybe life planning if they were going to get this, even though they couldn't do something to change the illness. But maybe it's different in this patient, as we kind of alluded to earlier. Really, there's not data in folks that have antidepressants at age 30 that they will truly go on to get an alpha-synucleinopathy. So I think counseling should be a little bit different here. How we would approach this, I think that's tricky. Even with any patient, somebody with more anxiety, might really handle this differently than maybe somebody without. So it's an interesting topic that's definitely, if you look at this literature, there's been a lot about it in the past. And then just some RBD demographic age-related differences. Isolated RBD is predominantly a male disorder that usually emerges after age 50. But there have been cases of RBD in childhood up to age 88 reported. RBD emerging before age 50 tends to have different demographics than including greater sex parity, so more even between the sexes, and increased rates of parasomnia overlap disorder, more comorbid narcolepsy, more antidepressant use, and sometimes linked to autoimmune diseases. Clinical presentations may be different than older adults too, often less aggressive. So his was kind of like a yelling sort of phenotype, but and kind of aggressive. But we with narcolepsy, we generally don't see that, which is interesting, which we think has a different pathophysiology related to orexin. And it's question too if some of the different aggression might be different with females versus males. There have been some studies in dreams in females where they tend to be less, the dream content in general tends to be less aggressive or violent, but that might have to do with societal roles and other things. So, but again, maybe different in him versus somebody that's older. And then this all comes out of the ICSD 3TR. So unresolved issues in future directions. The male predominance of RBD reported in earlier studies, maybe at least in part due to underdetection in women. Women do live longer than men, and maybe women are better witnesses than men. It's unknown if specific RBD subgroups are at increased risk to get Parkinsonism or dementia. These subgroups include those younger than 50 with antidepressant medicines or underlying neuropsychiatric disorders or PTSD. So those all need more study. New antidepressants or other psychotropic agents developed for clinical use should be assessed for their immediate and long-term effects on REM sleep without atonia, REM phasic activity, which is how dense the eye movements are in REM sleep, and just REM sleep behavior disorder and the proclivity to get dream enactment behavior. So I want to make sure that we give some time for Megan to talk. I have another case, but I'm going to save it for later, given where things, how things went. But before I turned over to Megan, any additional questions that you have or thoughts? Glad to try to answer some of them here.
How was he treated in the end? Like, did episodes like decrease in frequency, let's say, if you helped with his anxiety or anything like that?
That's a great question. Yeah, like with the anxiety, so I followed him regularly. He's due for another visit, so I need to kind of see when he's set to come back. But I mean, I think one thing that I worked through with him was we kind of just looked at it that everybody's at some risk for Parkinson's disease. Like I mentioned, this sadly, 1 out of 1,000 of us are going to get it. So just how much higher is he than somebody else? And he might really not be, that much higher. I don't really have the data that he's at risk for it. We kind of tried to focus on that and how much, and we're all at risk for a lot of other scary things. We're all at risk to get cancer of various types. So we kind of just tried to look at things holistically just to kind of help with that anxiety, but he was working through that. And then in terms of treatment, seeing if there would be a different antidepressant other than like an SSRI. So bupropion hasn't been associated with dream enactment behavior. I think his episodes had calmed down. I think he wasn't as bothered by the dream enactment behavior because it was relatively infrequent when I was seeing him. It was more, again, this anxiety associated with it and just what to do about the sleep apnea, where we kind of re-looked at it and in the end weren't really convinced that he had sleep apnea with some follow-up testing. All right. Well, let me turn it over to Megan. I'm happy to, if I see to answer any questions later too, or outside of this. So thank you very much.
That was great. Thank you, Mark.
Let's see if I can stop sharing my screen here. Let's try to do that.
Okay, sorry, I'm just gonna.
Dr. Garwood, it might be near the top of it where there's like a little small red thing that says stop share.
Thank you, Isaac. Let's see here. Got it.
Okay. Can everyone see my slides okay? Yeah. All right, cool. Okay, so let me. All right, so hey, everybody. I'm pretty sure I know everyone in this room, but if I don't, I'm Megan. It's nice to meet you all. All right, so following up Mark's very comprehensive, mine is still much more of a work in progress. And it's one that I feel like I've asked a number of folks in this division about already. So if you've already heard about this, I have like updates, but I appreciate the help thus far and continue to appreciate the input from all. But I do think it's a useful teaching case because I have spent a lot of time reading and trying to learn and talking with pharmacists and things like that about the specifics of this one. So with that in mind, I've got no conflicts. Goals and objectives, so review intricacies of a complex case and to try to solicit input from all of you smart folks. So go from there. So the clinical question, again, I think a lot of you have probably heard me bring up this case before. I've been following this patient for 3 years now. So in the setting of well-controlled sleep disordered breathing with ongoing excessive daytime sleepiness, which stimulants pose the lowest risk of arrhythmias in a patient with a history of pre-existing ventricular dysrhythmias. So this patient has quite a long-standing history. Like I mentioned, I've been following for 3 years, but that's only a very brief sort of snippet of her history to date. So the overview for her, she's a 79-year-old female. She's got a history of hypertension, and I'll bring up that she's, even before I got involved, had been on multiple antihypertensives, most recently amlodipine, Coreg, hydrochlorothiazide, and lisinopril. Type 2 diabetes, CKD, prior history of blood clots. So she's had DVTs and PEs that have been thought to be unprovoked in the past, has some ensuing component of pulmonary hypertension on top of that. Obesity or BMI is sort of vacillated between 40 and 45. Depression, IBS, chronic pain, a maybe history of bipolar disorder from her chart review, reflux, multinodular goiter, fibromyalgia, suspected polymyalgia rheumatica, chronic pain, history of TIA, and then mild sleep apnea. So we've got one baseline study from her back in 2002. On that, she had an AHI of 5.8. Her REM AHI was 13.3. The study was limited, but mild, and has this reported history of narcolepsy with cataplexy. And she came in to see me for some ongoing daytime sleepiness. This is just like a quick snippet of what her Epworths have looked like. So persistently sort of in the 20s, as we'll discuss. So as I mentioned, this particular patient has a very, very long-standing sleep history. So basically, she was diagnosed in the mid-90s. So she was diagnosed with sleep apnea and narcolepsy out at Hurley Medical Center. She has since told me she underwent multiple spinal taps. She wasn't entirely sure why those were done. She, has had a lot of medical issues over her life and has undergone a lot of testing at a lot of different medical centers. She thinks it might have been for narcolepsy. She was seeing a neurologist at that time who was also taking care of her sleep issues. Unfortunately, none of this testing is available for review, but since that time, she's carried this diagnosis. As of the early 2000s, she established care here. So, again, as I mentioned, she underwent a PSG in 2002. That was a repeat from Hurley. It showed mild OSA. She did not have a repeat MSLT or any formal sleep evaluation for essential disorder of hypersomnia done at that time. She underwent, I think, somewhere in the realm of like 6 to 8 repeat titration studies, sometime between 2002 and 2012 for ongoing sleep disordered breathing. The testing ultimately recommended BiPAP at 17/13. I don't think there's any notes in the EMR before 2012, at least none that I can track. But at least as of that time, when I was looking at the notes from the sleep provider she was seeing then, she was maintained on positive airway pressure. She was on BiPAP, and stimulants. So by then she was on Nuvigil 250 at noon, and then was also taking Ritalin 40 on awakening, and then an additional 20 milligrams at noon for this history of narcolepsy. I went back through the last like 10 plus years, and I've never seen an Epworth in this chart lower than the low 20s. I think the lowest that I saw was 16, but that was after she declined to answer a portion about driving and watching TV, because at that time she wasn't doing either of those things, but never really lower than 20 if it was being fully answered. At some point, she was also prescribed Ambien CR for unclear reasons. I thought perhaps there would be some sleep fragmentation or something like that, but nothing that I could really identify in the chart. This was discontinued by another provider in 2021, given some concerns that this might be contributing to daytime sleepiness, but had no impact on those symptoms. And you know, again, going along with this diagnosis of narcolepsy with cataplexy that she carried when she established care here, she described her cataplectic episodes as periods of hand weakness that were associated with emotion, as well as periods of feeling overwhelmed while at church. No other sort of like, you know, more diffuse types of symptoms or things like that. You know, there had never been any concerns about like syncope, or like she had never had a seizure workup elsewhere that was, you know, ultimately attributed to cataplexy. It was specifically this sort of atypical hand weakness. So I established care with her in 2022. At that point, she was on auto BiPAP. The settings are there. So she had a pretty minimal pressure support gradient. So it's you know, she didn't have a huge gradient or anything like that. Was still reporting ongoing issues. Oop, I'm in Brighton and the light just went off in the room. Okay. She was still having issues with ongoing daytime sleepiness, so her Epworth at that time was 20. She had poor sleep hygiene, insufficient sleep when I was chatting with her. So sleeping about 5 to 6 hours a night with no consistent sleep schedule. Then again, as I mentioned, issues with chronic pain and depression. We talked then because I was just sort of getting to know her, and it seemed like this sleepiness was multifactorial. We talked about repeating a PSG and MSLT. She declined that. She told me that she felt like she would need to be hospitalized if she was to be maintained off stimulants for 2 weeks prior to testing. And we talked about that wasn't really a feasible option. I asked her to keep a sleep diary. I referred her to behavioral sleep med, but during the visit, she denied any issues with insomnia or sleep timing. I asked her to follow up with her primary care doc for her depression. At that time, she said that her depression wasn't a concern and that she didn't feel like her chronic pain was contributing. And we had multiple risk-benefit discussions. Again, I was concerned given the fact that she was already on 4 antihypertensives at this point and had this history of PH. And so throughout these risk-benefit discussions, she was pretty adamant that the sleepiness was so debilitating to her and that she'd been on the stimulants for such a long time that they were really like a necessary thing for her. I also had chatted with her cardiologist at that time who called me after one of the visits because the patient was so distressed at the idea that we might try to wean the stimulants, and basically said for right now, she thought it was reasonable just to keep them going because otherwise the sleepiness was such a debilitating problem. In 2023, then things got a little bit worse. So she gets admitted with a DVT-PE early in the year. There were a lot of issues during the hospital stay. She wasn't getting the brand name medications for her stimulants. She was really struggling with sleepiness. She actually checked herself out of a SAR as a result of that. So she didn't actually complete rehab because of the sleepiness issue, because she wasn't getting her brand name stimulants there. Several months later, she develops intermittent palpitations. Her cardiologist had ordered a Zeo patch. It showed a 5-beat run of VTach and then 3 runs of SVT with frequent episodes of tachycardia. She was actually then hospitalized in November for palpitations. She had a negative ischemic workup. From the notes, it sounds like the team was primarily concerned that this was a primary cardiac etiology for these palpitations. For the patient, this was hypoglycemia mediated and resolved once her blood sugars had stabilized. She ended up with an echo after that. She had an EF of 62. It showed normal diastolic function. She had mild aortic regurg and mild tricuspid regurg. Her RBSP was 30, which is sort of where it had been living over the past couple years. And at that point, her cardiologist asked me to come back in and reassess the stimulants given this history of arrhythmia, and were there any stimulants that may be less arrhythmogenic. So I saw her in December. I spoke a while with the MedUse pharmacy team here, and sort of the consensus was, if we have to keep her on a stimulant, or we're trying to minimize risk here. The Nuvigil is probably lower risk than the Ritalin. So we held the Ritalin at that time. And through some shared decision-making, we talked about doing a polysomnogram with an MSLT to try to reestablish her diagnosis. And in that case, see if we might be able to qualify her from an insurance standpoint for something that may be less arrhythmogenic. So for example, looking at either pitolisant or Xywav. So unfortunately, we ran into a lot of like scheduling delays. So I went on maternity leave at the beginning of the year, which I think posed some difficulties. So many of my colleagues might have gotten messages from this patient, but I think she was quite distressed that I wasn't there for those couple of months. The PSG actigraphy MSLT couldn't be scheduled then until July. So she was off of the Ritalin during this time frame. She was only maintained on Nuvigil. And had significant frustration about this. She basically told several providers, including me when I reached back out to her when I got back from leave, that the sleepiness was debilitating and that this was ruining her life. So we got the testing done at, it was sort of the perfect storm. We couldn't get the actigraphy because there was a download error. So we missed part of the testing. PSG, shout out to Nisha on one of her first studies that she read. So it was done on her auto bi-level home settings. Very strange. So during the first half of the recording, the sleep disordered breathing was well controlled, but then later in the night, she had evidence of Cheyne-Stokes breathing during non-REM with a residual AHI of 23. I don't know why this had happened. So this was a pretty significant discrepancy between her polysomnogram and the download. She had only ever had a residual AHI of less than 5. So I definitely was not expecting to see this, but we thought maybe a potential contributing etiology. And then she underwent the MSLT. She had not stopped the Nuvigil prior to testing. Unfortunately, we didn't have a urine drug screen. And on this test, she slept on 4 out of 5 naps with a mean sleep latency of 10 minutes to sleep onset and saw REM sleep during 3 of the naps. So ultimately, the findings did not support a diagnosis of excessive, do support a diagnosis of excessive daytime sleepiness, but were not consistent with criteria for narcolepsy. So I guess at this point, I reached back out to her to discuss options, and we were concerned then that, things like pitolisant and Xywav might not be options here, or at least ones that, we would readily get authorization for. She was incredibly frustrated by this MSLT report. I think she told me, I'm trying to remember the exact words, something along the lines of like feeling discouraged and humiliated by the results because she had carried this diagnosis of narcolepsy so long, and really so much of her identity was tied into this specific diagnosis. And so we spent a lot of time, trying to reestablish our rapport and try to, reassure her that, the testing was abnormal. It just didn't necessarily meet the formal criteria that we were looking for. But I think this was a huge barrier for her and was a very difficult thing for her to see. We ultimately got a PAP retitration based on the fact that the residual AHI was so elevated. So that was done in August. So at least that was a pretty good turnaround time on that one. So the study ultimately recommended BiPAP at 20/16. But again, we did see some things that looked like periodic breathing. It didn't meet criteria for Cheyne-Stokes, but she'd had a relatively normal echocardiogram, at least at that point. And then I saw her back about a month ago. So her Epworth remains at 20. Her residual AHI looks just fine on the download on the fixed BiPAP settings. Currently, the bedtime for her is very variable. She's frequently getting into bed around midnight, but she tells me she only goes to bed when she's tired. Her wake up time is also very variable. So she'll take the Nuvigil 250 when she first wakes up in the morning to use the bathroom, often between 6 and 9 a.m. And then told me that she'll go back to bed because she's in a stupor and feels like the Nuvigil is doing nothing. Was having very frequent nocturnal awakenings with variable sleep latency after that. Couldn't really tell me how long she thought that she was actually sleeping each night. Sometimes napping, sometimes not napping. And then told me that she thought it's like a cloud was in her head. It's defining my life right now, and I don't trust myself to not go to sleep. So at that point, this was about a month or so ago, I talked to her cardiologist. So at this point, this is the 3rd cardiologist that she's seen since I've been involved in her care. This cardiologist felt that stimulants in general were very high risk and was a little bit reluctant to comment on like safety profiles. We again attempted to have a risk-benefit discussion. We stopped the new vigil at that point because of the lack of perceived benefit, and instead thought, well, maybe we could trial Sunosi. So as I mentioned, she's got CKD. So I talked with pharmacy. We started her on 37.5 milligrams based on the renal function. I ordered some genetic testing. So I ordered an HLA antigen, which isn't perfect, but I thought, might be a useful test. And then the other thing that we had discussed was a possible LP, although practically speaking, I've never actually ordered a lumbar puncture to check for an orexin level. So I'd be curious if anyone has any experience with that. And then in the interim, I've spoken with her again. She's had no improvement in her daytime sleepiness on the Sunosi. We increased the dose to 75. She's had no improvement in her symptoms. So that's kind of where I'm at right now. I would say that's kind of the most recent update since last week. She hasn't completed the genetic testing yet, as I mentioned, and I've been trying to look into whether or not an LP might be feasible. But I think just before we talk about group thoughts, which I would love to hear, just a few like confounding issues, things that I've already brought up, for this case, but I do think are maybe making things a little bit more challenging. I would say this is a patient who has a lot of distrust of the medical system, which I think has been a difficult thing. It's understandable. She has a lot of medical issues, and I think she often voices frustrations that she feels like doctors aren't talking to each other and that there's just too many cooks in the kitchen, and she's right. So in the time that I follow her, I established with her in 2022. She's had 4 primary care providers. She's had 3 different cardiologists in this time frame. She's followed with multiple subspecialists, me, rheumatology, general pulmonary, general neurology, nephrology, geriatrics, PM&R, and endocrinology, and then has different subspecialists at a variety of different hospitals. So she has seen folks here, out at Hurley, out at Corewell, out at Henry Ford, including overlapping subspecialties, which I think has made things confusing. Delays in testing, like we mentioned. And then again, I think this view that narcolepsy is part of her identity, and that by, trying to adjust the stimulants or tweak the stimulants, I think there's almost like a defensive element where I think she sort of feels like I'm questioning how she's feeling, or, that I'm doubting that in some way. And so I think a lot of what we've been working on is trying to rebuild trust, because I think that she almost felt attacked that the stimulants were taken away. And again, it's a longstanding diagnosis she's carried for 30 years. She told me she couldn't hold down a job prior to this diagnosis. She felt abused by her teachers as a child because of her sleepiness, and all of this had been very distressing. So I guess I would love any thoughts from the crowd, but are there any questions, I guess, in general that I can answer about this case?
Megan, I have a question. Thank you for sharing this case, and I agree with the challenging nature. And I think we do experience this sometimes with chronic disease management. Can you remind me about about cataplexy, if she has it, or what those episodes are like?
So she's told me that in the past she's had intermittent episodes of hand weakness that she thinks has been brought on by emotion, but she can't really give me an example. And then most recently, she's had episodes where she has felt overwhelmed while she's in church, but it seems like it's more of just a sensation of feeling overwhelmed. Helena had seen her once in the past as well. And I think at that point, she described an episode of almost blacking out in church, but that one did sound like that was more of a hypoglycemic episode. Someone gave her juice and she felt better after.
So I struggle with what to do when it's, kind of atypical cataplexy at best, in terms of the LP and the HLA typing, because I feel like those are described more in cases of very clear cataplexy. So then if you have atypical cataplexy, and especially with the HLA typing, like what do you do if it comes back positive? How does that change the management? And even with going the LP route. So I struggle with that too in these patients that are a little
I know. Because the HLA thing I kind of went back and forth on, because if it's positive, why is it just positive and there's nothing really that I'm doing with that? So the LP, I guess, with the history of like some maybe, I mean, is this atypical cataplexy with the hand weakness episodes? I don't know, is this like partial cataplexy? If the orexin level is really low, is that a more compelling thing? I've been reluctant to go down that pathway also just because I think not only is it difficult to get an LP done for this purpose, but also with her BMI and her chronic pain issues and like back issues, I do think the actual logistics of performing this LP, even under fluoroscopy, will be quite challenging. And, again, it's something I've tried to discuss with her in the past. She's not super jazzed about having it done, but basically has told me multiple times that if there's anything that's on the table, she would automatically take it because she's so entrenched in this belief that this is narcolepsy. And again, her sleep testing is not normal, even though she didn't have any decrease in her mean sleep latency. She also was on stimulants leading up to it, so that might impact things. I'm not trying to discount that, but I also do think that, her sleep patterns and other things, I think this sleepiness is very multifactorial, but she is very unwilling to work with me on like sleep hygiene, sleep timing, that sort of thing. I think because in her mind, it's always been, I'm sleepy because of narcolepsy and I take my stimulants.
I don't know, not seeing in this Zoom how to raise my hand anymore.
That's okay.
But so few things. First of all, I do think that getting the haplotypes that you did, I think it can be useful if it's negative. Because if it's negative, you'll say, well, that wasn't cataplexy. Most,
Sorry, I'm sorry, Ron. My like little, that like Siri thing that you can sometimes hit on the keyboard just went off, and so I missed the last thing that you said.
Oh, I just said that if it's negative, you'll say it's not cataplexy.
Mm-hmm.
And so I get it on occasion when I hear a cataplexy story and I'm not sure about the cataplexy.
Okay.
You're right, if it's positive, it doesn't tell you for sure.
Yeah.
And by the sound of it, by the way, if I had a nickel, I'd say it's not cataplexy. But
yeah.
Then the other thing is, why did we have to tell her she doesn't have narcolepsy? Is it because the mean sleep latency was 10 minutes instead of less than 8? And then she had 3 cell REMs?
Yeah. So I guess, I didn't, so Ron, actually you read the study with Nisha. So I remember talking with you in July about this one, and you brought this point up, which I thought was very fair. So what I told her was, because she also saw the report that said like, this does not meet, our society criteria for narcolepsy. And so that's what I told her is like,
Right.
the time that it took you to fall asleep by our criteria did not fit with narcolepsy. However, your sleep testing is very abnormal. And I cannot say that this is not narcolepsy. It just, this specific test didn't fit this criteria.
Right. And we know it's not a perfect test, and we
Right.
take everything into account. I mean, is it a crime if we just would continue her diagnosis and say probable narcolepsy or something? Is that like we're going to get sued because we're getting her medication she's not entitled to? I think it's crazy.
Yeah.
Personally, I wouldn't disappoint her. I'd say, well, we couldn't find the smoking gun definitive evidence, but we still think, based on your whole story, that it's likely to be narcolepsy or else some narcolepsy-like condition, even if we can't call it exact, and which it is, doesn't affect so much what we give you, but it might affect insurance coverage, unfortunately. So,
Yeah.
that's my 2 cents. Some of the story, it does sound like idiopathic hypersomnolence.
Yeah.
Like the morning, how long it takes her to get going. It sounds like she has real sleep inertia. I don't know to what extent she feels, I don't know. But I think other people have questions too, but those are my initial thoughts.
Yeah.
Megan, I think, so I agree with Ron. I think you can call her narcolepsy, and I've done this many times. I think you would write narcolepsy type 2 because she doesn't have definitive cataplexy. And then in your assessment and plan, and have had this work with insurance companies sometimes, I
Okay,
write that due to the test retest unreliability of the
Okay.
MSLT, which is now, it's very well known for narcolepsy type 2. So that would kind of coincide. But
Okay.
that's just like one part of this. I think the bigger part of this is she has issues with her perception of sleepiness.
Yeah.
Because, I mean, when you look at patients with narcolepsy, even that have like mean sleep latencies of like 1, 2, 3 minutes, and they're not even refilling their stimulants regularly. Like,
Yeah.
I think her perception of sleepiness is problematic. And did you say she sees a psychiatrist?
No, and she's really adamantly refused to see one. So I brought this up early, and she got quite
Well,
angry at me for suggesting that might be contributing.
well, I would say that this is her experience of symptoms is outside of what we would consider normal or typical for narcolepsy. You can say, I do believe you have narcolepsy. There's test retest reliability, but your experience of your chronic symptoms is clearly very debilitating. And so I think she probably needs some psychological or psychiatric guidance for the experience of her chronic disease.
Okay.
Because it regardless of like what her haplotype, even if you got an LP and she is, you know, her levels are less than 110 for orexin, it's like, what are you gonna do? Like, I wouldn't feel safe putting this woman on Xywav or Xyrem, to tell you the truth, with her other medical problems.
I know,
And
I
so
know.
all you have left is pitolisant.
Yeah.
And
So
I
that-
doubt that'll work. It's just
Yeah.
this like chronic issue with her. And so you have to tell her, you know, you think you're at the limits of what medication can do,
Yeah.
and that she needs some assistance for her. You know, you obviously you are hearing her, you're not doubting her, but because of this debilitation, I mean, there's like health psychiatrists and things like that, I think, available.
Yeah.
But
Yeah,
I deal with it with like, for some reason I get like, I think we all do, but I feel like I get a ton of the chronic fatigue patients,
Mhm.
and like even ones that come back with mean sleep latency of like 15, and they're like, well, you still have to help me. I'm exhausted, da, da, da. And this is kind of the conversation that we have.
Yeah, yeah. No, I think, thank you, because you know, it has been a little bit frustrating, because I also feel like I do feel like I'm getting like backed into a corner to do something I don't think is like I really I'll say this. She sees 3 separate cardiologists through our system now, one of whom has said there's no issue with being on stimulants. This is stupid, and has written in the chart like, I don't know why Dr. Acho is ruining your life. She has seen 2 other cardiologists who have told me like, this is very high risk. This is a bad idea. And so I don't feel comfortable with, you know, being the person that's prescribing someone who's had VTAC before a bunch of, you know, some pathomimetic agents that are going to potentially make this worse, especially when I'm not actually like subjectively, I think some of the benefit that she thinks she's perceiving might just be because she's been on them for so long. But like, from an objective standpoint, her self-reporting of symptoms really has never changed. And so like we've had is the juice worth the squeeze convo, and
I mean, you have some rights in this situation, right?
Yeah.
And this is essentially, I mean, and your like ultimate is do no harm, and this is encroaching on like your right to practice without doing any harm.
Yeah.
So like, and it doesn't negate her diagnosis or how she feels, but I think like, I don't know, I personally think it's time for boundaries with her. Unfortunately, I don't think it's finding the perfect medication or like nailing the diagnosis unequivocally.
Yeah.
That's just me. I'm probably echoing what you've thought before, though.
Yeah, it's nice to hear it from the group, though.
From one of the old people.
From someone seasoned.
Yes, seasoned.
I have a question.
I think Punita had her hand up also.
Hello, can you hear me?
I think somebody is talking, but I'm having a hard time hearing.
Can you hear me?
It's hard to hear you, Punita.
Oh, even when she was on Nuvigil and Ritalin, she was still complaining of excessive sleepiness, right?
Yeah.
Okay. But I'm not sure, you know, I mean, that itself tells that we know her sleep hygiene was poor and all other, you know, confounding factors in there. Is the Vakix is the better medication for her?
Sorry, I think I missed the
Is
last one.
Is the pitolisant is the better medication for her since she started on that?
She hasn't started that one yet.
Ah, okay.
She's been on Sunosi now. Yeah, my thought was with the MSLT, I could probably try to get her pitolisant, and I very much agree with the group that I'm not super jazzed about doing Xywav or Xyrem in this case, because I think it's just going to be a disaster. But pitolisant I thought seemed at least relatively low risk, and at least then I feel like I can honestly say to her, like, look, I feel like I've kind of exhausted what we can do that seems safe in this scenario.
Hey, Megan, I might have missed this, but has she had a period off of her traditional stimulants, like for a month or even?
Well, inadvertently. I stopped the Ritalin for 7 months when I went on leave and the study got delayed, but she was on the Nuvigil that entire.
Okay, Nuvigil.
She has never completely been off stimulants, and like that, we did talk about that, as a trial, just to see, like, because you're still so sleepy and it doesn't seem like this is making a difference. Do you feel any different? And she has adamantly refused that in the past.
And I might wonder if pitolisant didn't work. I like that idea, provided like cardiology wouldn't think that she'd be at a higher risk. Certainly we've got a lot of cardiologists could weigh in if she'd be at higher risk for QT prolongation, given her known cardiac pathology, but maybe like an EKG ahead, she's probably at a lot, could see if she's at risk, but getting their feedback there. But I like that idea. Plus or minus, and then maybe even if that was ineffective, maybe adding Provigil or Nuvigil if she in combo therapy, because I think that maybe less sympathomimetic effects with Provigil and Nuvigil, if she needed more versus like a traditional stimulant at a high dose, which I think
she'd never had a Holter just on the Nuvigil. So when she had the Zio patch done, it was on the combo of the Nuvigil and the Ritalin. Yeah, I guess like that. So that was also something in the back of my mind. And what I had talked to cardiology about was if we were to be starting and adding more, we would run like a Holter and, as an outpatient and try to see and ensure that she wasn't having some like malignant arrhythmias. But like, I don't know. I feel like what I keep coming back to is it really just seems like nothing is improving this. And I do so strongly think that this is like multifactorial. She's just not, I don't think she's just receptive to meeting me halfway on any other issues, that it's become like a real barrier.
Megan, I have a question. So have you considered an MWT? I mean, I have heard that the patient, this is likely multifactorial and perhaps, mental health may be involved. And then her perception about this being actual sleepiness versus being actually fatigue. I was wondering if, you can perhaps, collect a little bit of more information about, objective information about her sleepiness and kind of reflect that to her and perhaps kind of support some other, recommendations, for example, seeing psychiatry or someone else, right? I'm not saying that you necessarily need to, kind of just shake the responsibility, but at least, bring someone else on board because, based on what you're saying, she's a very complex patient, right? And then I guess as Dr. Goldstein was saying, it's going to be very difficult to find the right medication or the proper combination for this patient. So I guess, any type of information that will help you, kind of give the patient some context and some reflection about, whatever is happening to her, I think it will be perhaps beneficial.
Yeah. I've never actually ordered an MWT, but no, I had not thought of that. Yeah, but thanks. Cool.
I don't see any other hands up. Thank you, Mark and Megan, for really interesting cases.
Happy holidays, everyone. Thanks, everybody. This was helpful.